Sometimes you need to stop and think about what you're doing, and in the NHS we're not very good at that because we tend to do the same sort of things in the same sort of way, and sometimes we don't give ourselves the time to just reflect on whether we are truly adding the best value.
What frustrates that GP? For me, it's often that I know what my patient needs, but the system doesn't necessarily support that in the best way for the patient.
You've got to take that brave decision, challenging the actual norm, and actually saying, well, actually, you can't do it like this. You've got to ask the questions.
Population health management is just simply evidence-based learning to inform change, whether that be at clinician, individual patient level, but also service level, service planning level, from patient all the way to system and back down again. But ultimately, in terms of a principle of way of working, it is to use evidence to inform change, and then a cycle of improvement that goes on from there. So everybody really should be using the best information that is to hand to try and inform what they do, whether you're a clinician or a service manager.
To really embed this approach of population health management, we need to have joined up information systems to start with. We are used to silo planning by seeing the data and the actuarial modelling for the whole system. We are able to see them all in one.
Using a PHM approach to the management of COPD allows you not only to stratify your patients in a slightly different way, but it allows you to translate that into a new care model that looks after people more appropriately for the level of severity of their disease. What I call data-rich, intellectual, intelligent decisions about the way that we are looking after patients, which may not be in the traditional way, and it may not be a purely transactional way, and it may mean that we need to develop new relationships outside of our natural health circle to be able to deliver care in its widest sense, in its truest sense, but in its most holistic way.
So population health management to me involves not just looking after an individual patient in front of me, but a whole community, and we look at their health needs across the whole patch, and we then try to plan care and services around their needs. It involves trying to analyse what those needs are, analysing data. It's not just one particular provider, it's not just general practice. It involves a whole community, all the assets in that community. So it's a real mix of how to match the population needs to the provision which is in the community.
We have an awful lot of information available that we collect and we use, but we don't spend the time to analyse it to truly understand what it's telling us. We tend to get very focused on single processes of care rather than the system of care, and recognising that different parts of the population, possibly with the same condition or more than one condition, have different needs and a different way of meeting that need rather than just one size fits all.
And where you have to get to really is the data is part of the picture. So the data is informing what you're going to do in terms of to improve outcomes, get the best value, but you add that into what is frontline people's own intelligence, what you know about the community, etc., and your own, relationships, what's best. So it's part of the picture, but yeah.
Yeah, I think the data by itself isn't enough, is it? It's about how frontline professionals who understand and work with communities use that data to identify where they can have the biggest impact on improving outcomes for people.
It is so important that we really, really robustly do the analysis, but that is only 10% of what is involved in managing the health of a population. The rest is actually bringing about change, working with people, developing relationships at various levels, and changing the way we pay for things, and changing the way we monitor outcomes. If we don't do two things, if we don't use the analysis to generate actionable insights, and if we don't actually act on those insights, there's no point in population health management approach. It's just an academic exercise and some graphs and charts.
Looking at the data, looking at the analytics that's provided, crucially what we're designing is actually based around the patient. Picking up the phone, talking to individual patients, finding out what's important to those patients, to them in their lives, to design systems around what they need. That much more flexible, much more nuanced approach is the key element of population health management.
There's nothing better than seeing that you've had an impact. As professionals, we have the advantage of knowing the ultimate costs when things aren't put in place. Part of our responsibility is to enable people to understand, you know, what could potentially happen if we don't provide timely interventions and we don't support them. And also it's about identifying what they can do for themselves. You know, it's not about a do-to approach. There's nothing greater than seeing an impact change in potentially a path that somebody could have taken and what that could have meant for them.
Let's just go one step at a time. Let's get the data and just see what it looks like. And from that, it will tell us a story. With the whole of healthcare at the moment, there's always that juggle and that conflict of time, pressure. Having said that, I think this is really important, and actually I think we will see a long-term benefit. So you might have to invest a bit of time to start with.
People starting PHM now have got a real opportunity in that primary care networks are now established across the whole country, and they are the people who will help drive this. Primary care is an evidence-driven, digitally informed group of professionals, and they are ready to respond. And as long as we give them the flexibility and a bit of headspace to actually start to think about how they may change the way they work in order to be proactive, not reactive, that group of people will really succeed. We've got to hold our nerve. This does not deliver in 6 months. This is a long-term project.
If we get a whole group of a social movement coming forward and actually sort of saying, well, no, we've got to work very differently. The challenge is, I think, that the complexities of the NHS also needs to be brave, sort of step up and say, okay, we're not going to run the organisations as we have done in the past as such.